Sorrel Gandhi, just parked the car. Got a little bit on my mind right now. Think about this IR DR hate, Why is there this IR versus DR infighting? Can't we just get along? There really should not be this IR on DR hate. And it bothers me, because as an interventional radiologist, I know I have the best job in the world. It is the best job in the world. On the one hand, I am an interventional radiologist. I'm a surgeon. I'm not trained as a surgeon, so I'm not a surgeon, but I'm surgeon-like, surgeon-esque. I do cases in a vascular lab. I see patients. I consult with patients, make clinical recommendations. I treat patients, and I perform procedures, which are hugely satisfying to me. So I love practicing as an interventional radiologist. But I also have the option to do something almost completely different from that, where I can go into a dark room by myself, no one else around. I can put on my headphones, and I can interact solely with a computer, and it's just me and the computer, and how many cases can I get through as safely as I can get through. How many cases and how many patients can I help with my mind, my eyes, my voice, and the computer. And that's the life of a diagnostic radiologist. And I can choose to live any combination of those two lives that I want to. I can do one the one day, the other day. I can do a mix of both throughout the day. I can decide to find employment where I'm working out of my home and then working in vascular labs at my own choosing, or I can decide to, at some point when I'm too old to wear lead, that I just want to sit at home and read cases. Right? So that's why radiology, to me, diagnostic and interventional radiology, is absolutely the best field in medicine. No doubt in my mind, because you can play any one of these two characters. But this hate, this IRDR hate, is just completely unfounded. We got to understand that IR and DR, I know IR is trying to split away from DR, and that's laudable, but they cannot. And that's because of just straightforward facts. They cannot split from diagnostic, and really it's always about one thing. It's about one thing only. It's about the money. All right? Why can a kid not leave the house? The kid cannot leave the house until the kid is financially independent. And that's the issue with IR. They're not financially independent. IR still operates in academic centers. IR operates under the Department of Radiology. Their salaries are paid for by the Department of Radiology. Their salaries are in fact subsidized. That's more of a, I'm pretty sure about that, but I don't have proof, but I'm pretty sure about that. Their salaries are heavily subsidized by hardworking diagnostic radiologists. Part of the salary of an interventional radiologist in an academic center is going to be subsidized by a hardworking, overnight diagnostic radiologist reading negative head CTs and nearly normal CT appels overnight, and producing those RVUs, and the cut of those RVUs is going to go to pay that IR his or her salary, even when they're up there on the floors interacting with clinicians and pretending to play doctor and trying to tell the ICU physician what to set the pressor rates at. All right, and the reason for that is because right now Department of Radiology kind of owns IR. Now, how could IR truly go independent? Well, IR has to truly go independent. They have to go financially independent. They have to do some things. So, like a theoretical example here, IR department wants to go independent. They gotta have their own equipment. So you have to go to your chairperson, and you have to make her. My last chair was a female, so I say you have to make that chairperson. You have to go to her and make an offer. You have to say, hey, I'm offering to buy out our own angio suite from you, from your department, and I'll offer you maybe $2 million cash. And what's she gonna say? Is she gonna accept that? How are you gonna get that $2 million cash? You're gonna need to take out a loan. You're going to need to take out a loan for your practice, and you're going to have to talk to your interventional radiology partner and say, hey, we're going to take out a $2 million loan. We're going to pay back over 20 years. Are you guys cool with that? We'll pay for it with collections from our procedures. All right? So we do that. We buy back our angio suite. We take out a loan. We take it on with the interventional radiology partners if you can find them. Hopefully you have some. And then you do everything yourself. You get your own management company. You hire your own techs and nurses. All right? You get your own billing company. All right, and have a billing company that specializes in IR, and you make sure that they know how to bill for the E&M codes that you are performing when you go up to see patients, and you know how to accurately code and document your patient consults, so you're getting revenue for that. Because if you really want to be independent as an interventional radiologist, you have to be independent financially. You have to own your own machines, and you have to do all your own billing or have a billing service that helps you with that. Is IR really ready to do that? I don't think they are, because when I look around, I see IR departments, they're not operating like that. They're operating under the Department of Radiology. They're using them just like a kid that stays at home after they're 18 is using their parents for income, for discretionary income, for health insurance, for support, financial, emotional support. They need their parents, and that's the same thing that IR, unfortunately, right now still needs diagnostic radiology for support. If you really want to be independent, go out and be independent, and then talk trash about diagnostic radiology then. But you really don't have to do that. I know personally of a physician who is acting independently, is working at independent vascular centers, is working with people that they own the equipment. He does the procedures. He's an excellent interventional radiologist. He does below the knee, atherectomy in the outpatient setting, etc. He does pedal access, all the most top-notch, amazing things as an interventional radiologist. But guess what he does on his days off? Goes to a station and cranks the list, and he can read head to toe. He can read MRI of the wrist. He can read MRI of anything. He can read CT of whatever. As a fellowship-trained interventional radiologist, to me, that's a real radiologist. You are a radiologist. Don't fall for the narrative, the false narrative that in order to be a good IR, you have to give up your DR skills. Not true. Not true. Not true for this individual, and not true in general. We're physicians. We have high intelligence quotients. We have high capabilities. We can do anything we put our minds to. If we want to practice the breadth of diagnostic radiology and practice the highest level of interventional radiology, it is totally true. I know it to be true, and that's the kind of practice that I hope to develop over the years. But yeah, just getting started. Just want to say some things. No need to hate on diagnostic colleagues. I know personally they work their asses off just like we do to bring home a check and share it with the fam. So let's respect everybody, and let's remember who it is that we work for. Because if we work for the Department of Radiology, that means that hardworking radiologist, diagnostic radiologist, helps pay our bills, and we need them. It's RoboMD.